All right. Hello, everyone. Welcome to the third installment of the Cardiogenic Shock Virtual Grand Rounds. My name is Shayna Costello. I'm the Senior Manager for the American Heart Association's Cardiogenic Shock Registry. We are thrilled to have everyone here with us today. We can go to the next slide, Marielle. And I just have a couple of quick housekeeping items before we begin. Please note that this meeting is being recorded and we will save the recording on our Cardiogenic Shock Registry website. We just ask everyone please remain on mute unless you are asking a question. Questions should be held into the designated times. We'll have plenty of opportunity for you all to ask those questions. Today's agenda is tight though, so we do recommend that you submit your questions in the chat to be addressed during those Q&A times. Next slide. All right, so I'm going to hand it off to Dr. Mauro. Dr. Mauro is a critical care cardiologist at Brigham and Women's Hospital, and he's also one of the co-chairs of the steering committee for the AHA's Cardiogenic Shock Registry Initiative. So I will pass it off to him so that he can overview what you can expect today.
Thanks very much, Shana, and welcome to everyone for this third installment now of the AHA Cardiogenic Shock Registry quarterly virtual grand rounds. We really have an amazing lineup today that builds on the incredibly important and rigorous trial data that we now have from the Danger Shock trial that I think have focused our attention both on the efficacy that we can achieve with mechanical circulatory support, but also the importance of safety. And that really is going to be the focus of today as we walk through first a didactic lecture. We'll then have the remarkable opportunity to have some comment from the FDA on their perspective on safety priorities and cardiogenic shock, and then pull it all together with a case that no doubt will spark some interesting discussion as well. If we could go to the next slide. And so it's my great pleasure to introduce Navin Kapur, who is one of the world leaders in cardiogenic shock, taking this from both an interventional and an advanced heart failure perspective. And I very much look forward to his presentation. Thanks for joining us, Navin.
Great. Thanks, Dave. And thanks, everybody. And thanks to the AHA for hosting. Really fantastic to be with you today. And I agree, the field is really moving very quickly. The momentum is growing. There's, a lot of opportunity to directly impact our patients. So thank you so much for the opportunity to talk about this topic. And the topic that I was asked to discuss today is to take a closer look at adverse events in cardiogenic shock, particularly after the Danger Shock trial results. So I'm going to focus my comments around that. So I think it's fairly evident now, and you've probably seen, the results of the Danger trial. But just to reiterate to everybody, the Danger trial essentially was a randomized study that compared early use of a microaxial flow pump to standard of care in patients with STEMI and cardiogenic shock. The primary endpoint was 6 months mortality. And as you can see from the middle panel, at 30-day mortality was around 45%, which is pretty consistent with other clinical trials. And then if you look at the 6-month mortality, there was a statistically significant difference between the microaxial pump arm and the standard of care, 46 versus 59%, with a reduction in mortality using the microaxial flow pump. And these numbers, 46 and 59%, are fairly consistent with the original shock trial from Judy Hockman many years ago. On the right, I just listed out the number of vasopressors that these patients were exposed to, and a close look at the SKY Cardiogenic Shock Working Group staging of these patients, where you can see a substantial number of patients were C and D. The reason why that is important is because when we look at the Danger trial, we're trying to understand exactly how this trial was able to thread the needle and actually end up with the first positive RCT in the field of cardiogenic shock. So one of the things that I like to do is this exercise in inversion thinking. So the way Danger worked in my perspective is that they really focused on LV dominant cardiogenic shock, which means they excluded patients who had concomitant RV failure. And by focusing on univentricular shock with the LV, they could apply an LV support strategy, which certainly makes sense when you look at it in hindsight. They also focused on STEMI cardiogenic shock, and they ruled out patients who had biventricular involvement, as we talked about, with eliminating the RV. But by focusing on STEMI, they also did not focus on non-STEMI, which has a lot of comorbidities. It's a very different patient population than a typical STEMI shock population. And of course, with AMI shock, they excluded out-of-hospital cardiac arrest so they could focus on patients who were salvageable. And they also, of course, excluded heart failure shock. So as a result, when you track backwards on the green boxes, you can see how the investigators were able to navigate the field of cardiogenic shock and focus on univentricular support for univentricular dysfunction. And one of the things that's important to note is that for out-of-hospital cardiac arrest, the AHA recently gave a Class 2A recommendation for eCPR. So this is a different category. And I think that's important to think about going forward. Prior to DanGer, most of the trials that had been used in this space or conducted really actually encompassed everybody. There was really no specificity around non-STEMI, STEMI, out-of-hospital cardiac arrest, LV dominance or RV dominance. And as a result, with these randomized trials, you can get very fast enrollment. But from my perspective, this led to a lot of confusion and really had limited clinical impact for the use of balloon pump and ECMO here in the United States, for example. Then there was a meta-analysis that followed the DanGer trial results, which talked about all of the different RCTs. And this really is an exercise in heterogeneity testing with this type of analysis. But having said that, even with that type of heterogeneity, you could see that from their results, they showed that with LV unloading devices, which was predominantly the Impella device, there was a significant survival benefit in cardiogenic shock. And they consider VA ECMO LV loading, and I'll just put quotes around that, but they couldn't detect a statistically significant survival benefit, even though there was a trend. Now, the focus for today is around the DanGer shock trial adverse event rates. I think this is a really important figure from the manuscript. It highlights the need for improved practice, clinical practice, as well as the need for innovation in the space of cardiogenic shock. And I won't walk through each of these in detail, but as you can see in the blue bars, there was increased adverse events in various different categories, including bleeding, limb ischemia, renal replacement, in stroke, and also in sepsis. And so I think what this is telling us is about the need in the space for improved focus on adverse events. And I'm going to take a little bit of a deep dive into each of these categories over the next 15 minutes or so. So just to reset for everybody, what we're talking about when we say mechanical support, balloon pump, Impella, the tandem heart is not really used as much these days, but you can bundle that with VA ECMO, for example. And when we say higher capacity LV unloading, again, univentricular support for univentricular shock, right now that requires fairly larger arterial access. As you can see in the Impella, that's around a 14 French sheath size, and it's a 21 French surgical implant for the Impella 5.0 or the 5.5 pump. And the contemporary shock algorithms really focus on this yin and yang, as was mentioned earlier, about Impella and ECMO. There's unloading strategies and there's loading strategies. And the combination of these two devices are really what drive most shock algorithms, contemporary shock algorithms, with early use of LV unloading, for example, in anterior MI or acute MI, and then using ECMO for eCPR, as we talked about, a cardiac arrest, and then considering escalation from Impella to include ECMO called ECPella. And this algorithm that I'm showing you is from Japan, but this is not a clinical study. This is their clinical practice. And with this sort of concept of door to initial hemodynamic support, then door to reperfusion and reassessing, they're integrating the cath lab with critical care in their most contemporary algorithm. Now, I'll talk a little bit about some of the data coming from the Cardiogenic Shock Working Group. And one of the areas that we're going to focus on in one of our upcoming reports is around VA ECMO. So as we talked about, there's Impella and there's VA ECMO, two main components of most shock algorithms. And VA ECMO in real-world practice, it's mostly non-surgical. So sometimes people think about VA ECMO and they think, it's always placed by a cardiac surgeon or a surgeon. But actually, the vast majority of VA ECMO we found is placed in non-surgical environments with peripheral cannulation. And what you see here in the pie chart is out of 1,700 patients, a split between heart failure and MI of about 45 and 34%. And mortality is about 42%, and heart failure shock about 60% with MI shock. The other category represents postcardiotomy and other etiologies of shock. And then what you can see on the right side is that there's this VA ECMO is predominantly used in Sky D or Sky E cardiogenic shock patients. But what's important to note is that 71% of VA ECMO in cardiogenic shock occurs in the context of another temporary MCS device. So actually, only about 29% of subjects receive VA ECMO alone. Usually, they've also been exposed to or will be exposed to a balloon pump, an Impella, or greater than 2 or more MCS devices. And when we look at the mortality range, you can see the range is again between 47 and 63% if you bookend the bar graphs. But notably, what you can see is that VA ECMO with an Impella 5.5, the surgical placed axillary device, it seems to be associated with reduced mortality, whether it's heart failure shock or MI cardiogenic shock. And this may be a suggestion that higher support using the transvalvular pumps may enable earlier decoupling from VA ECMO. The mantra with VA ECMO is that as soon as it goes in, we're trying to stabilize and get VA ECMO out of the patient to try to mitigate risk. And so this is some interesting observations from our early look at the data. In real-world clinical practice, this is the reality. We're basically talking about patients who get VA ECMO or an Impella or the combination. And when you add up all the different French sizes from the venous, the arterial, the Impella sheath, as well as the antegrade perfusion catheters, you're looking at 66 French worth of vascular access. So about a 22 millimeter hole if you combine that into all of the vasculature. And this is a significant risk for bleeding, limb ischemia, and other adverse events. And that's what we're finding. So when we look at our VA ECMO and MCS combination complication rates, in the upper left, it's important to note that the vasopressor inotrope score before initiation of VA ECMO was highest amongst patients who were supported with a balloon pump in that combination with VA ECMO, with a VIS score of 25, for example, in patients with MI cardiogenic shock. In the bottom left, you can see that the bleeding rates with VA ECMO and other MCS is about 40 to up to 60%. When you look at limb ischemia in the upper right, you can again see a range of about 11 up to 20% when you bookend the bar graphs. And again, the lowest rates we're seeing there are with the axillary surgical conduit of the 5.5. And then the stroke risk, which was really interesting to observe in our data set, ranges again between somewhere in 6 up to 20% is where we're seeing stroke. Now, one thing I wanted to focus on is this question of stroke, because it's not something we really have taken a deep dive into when we look at, some of the adverse event rates. But from my perspective, shock programs need to focus on heart and brain recovery. One of the paradoxes right now in the clinical algorithms and management of patients with cardiogenic shock is that we have strategies that can recover the left ventricle. But if someone has cardiopulmonary injury, cardiopulmonary failure, then what ends up happening is as the LV recovers, that deoxygenated blood coming in from the lungs gets ejected out into the systemic circulation. And if you're on VA ECMO, this can create north-south syndrome, where you have basically oxygenated blood from the VA ECMO circuit mixing with deoxygenated blood. And essentially, in the cephalad portion here, going towards the head, that's where you're starting to get this differential hypoxemic effect to the brain. And if you put in an Impella device in someone who has north-south syndrome, you could exacerbate that by essentially driving that deoxygenated blood north and essentially leading to, potentially worsening cerebral ischemia. And you can see that in this clinical case. This is a patient on VA ECMO with a mixing cloud in the yellow circle. And then when we add an Impella, for example, you can now see that the mixing cloud has moved to the right side. And so that's actually on the left side of the patient. And you can see there are the great vessels that are being perfused more thoroughly now that you're on an Impella configuration. But the question is, how do you detect that? So as an example of the need for better algorithms of care, this is data coming from Johns Hopkins, where they're using bilateral near-infrared spectroscopy patches on both sides of the brain or the skull to detect asymmetric cerebral perfusion. And if they identify that in those patients who have asymmetric perfusion of greater than 8%, they're seeing about an 83% risk of stroke or any sort of acute brain injury. So this is where I think, it's an example of how we need to get better. And we know now with the combination of Impella and ECMO, it can improve survival. And that's been shown on the left with the ELSO data, and the upcoming Unload ECMO trial with Benedict Schraga and Dirk Westerman is pending. But what they're showing is that this combination seems to work very well. But the question is, it can drive complications. So this is where we need to get better in our algorithms and also in our technologies. So next, in the next couple of minutes, I'll talk a little bit about bleeding. So bleeding is a really, challenging substrate. We talked about the 22 millimeter of vascular access that's required to support some of these patients. And on the left, what I'm illustrating is all of the things that go into best practices and the factors that may drive bleeding at the time of MCS implantation for somebody with cardiogenic shock. So this is a really nice review that everyone should take a look at from Van Edem and colleagues and JACC Intervention in 2023. And they show this early phase where bleeding risk is elevated. And then there's the support stage where I inserted the term support escalation, because that can obviously increase your bleed risk. And then at the end, when you're weaning and you're going to now explant the device, we don't actually have a uniform practice around device explantation for either ECMO or for Impella. There are different best practices out there, and we need to make that more uniform. Now, bleeding, as we talked about, it's a multifactorial target, and it occurs in cardiogenic shock with or without mechanical support. You can see in the IABP Shock 2 trial, both arms with the balloon pump or the control arm had about 16%, 17% moderate bleeding. Danger, it was 22% versus 12%. ECLS shock, 23% versus 10%. So there's bleeding risk in this environment. It is escalated or elevated by the presence of MCS. And then when you combine MCS, it can also be significantly elevated. And then when you look at the culprit shock trial, I pulled this figure mostly to highlight that in addition to ECMO and Impella as being risk factors for bleeding, in that trial, actually the use of adjunct pharma has a significant impact, the use of glycoprotein 2B3 inhibitors. And there's more data that just came out in Journal of Cardiac Failure for the use of Cangalor with the CAMEO analysis. So this combination of drugs and devices, they all work together. And if we don't optimize things, even just checking a 10A level at the time of explant or an ACT, these are the types of best practices we have to implement in clinical practice. The NCSI data from the National Cardiogenic Shock Initiative with Impella pre-PCI also shows similar data. I show this more for completion and another view showing that, again, transfusions around 23%, access hematomas and bleeding 6 and 4%, which is, again, what we're seeing. And despite that, they're showing survival to discharge of around 71%, and at 30 days at 68%. When I looked just briefly, I took a biopsy of our registry with the shock working group, and we can see, again, fairly similar bleeding rates for heart failure, MI shock. Post-cardiotomy shock, of course, in the surgical environment has a higher percent bleeding. And then, of course, when you look at the MCS technologies, there's a stepwise increase in the risk of bleeding, which is fairly consistent with other observations. Now, to mitigate bleeding, I think with technologies like Impella, we have to implement best practices. And this is where this list that came in this nice review starts to focus on prevention, optimal vascular access, bleeding source control, switching to bicarb in the purge, all of the adjunct pharma that we talked about. And there are newer technologies, and we hope that the innovation of smaller bore access leads to reduced bleeding. I suspect it will, and at TCT, we'll hopefully see some of the data around the ECP device. Now, hemolysis is another important aspect of cardiogenic shock and adverse event rates, especially with MCS. On the left, you can see the different factors that might be associated with hemolysis, device positioning, RV function, and preload. And on the right is just an important equation for people to understand exactly how this works. One of the major factors that determines blood damage index is actually the speed of the device and the exposure time. So essentially, if you're running an Impella CP, for example, at P8 for more than 24, 48 hours, and you're not getting adequate support, this is where you can start to raise that risk of hemolysis, and you need to think about early escalation to a higher capacity flow pump. Now, there's some emerging data, and again, I show this because of best practices. This question of malrotation or position of the devices, we can often be fooled looking at the fluoroscopic image or the chest X-ray. And the point of these images is to show that you really need a 360-degree view of the device to make sure that position is actually optimal in all of these transvalvular pumps. Suction with transvalvular pumps is another main driver of hemolysis, and this can be due to inlet obstruction, most commonly caused by low preload or right ventricular failure. And this is shown nicely by Babar Basir and his group, where they essentially just published in Journal of Cardiac Failure that the cumulative duration of suction events is associated with survival, meaning that if you continue to have suction events, this could be an indicator of worsening shock or shock severity because the RV is involved, and it's a driver of hemolysis because of that suction. So again, best practices, early identification and phenotyping of the patient to mitigate these types of adverse event rates. Hemolysis can lead to worsening renal function. So there's a lot of components that lead to worsening renal function. And these are some of them here: congestion, low output, hypoperfusion, and then, of course, drug and device factors that can lead to vasoconstriction in the microcirculation of the kidney, as well as hemolysis or other effects from devices. When we took a biopsy, this is work from Rachna Kataria and Shashank Sinha, basically looking at worsening renal function. In our data set, what we're seeing is that with drugs only, so patients who are only exposed to drugs, worsening renal function occurs in about 30 to 34% of patients. When you add a device or technologies in there, it goes up to about 46 to 47%. So again, putting into perspective drugs and devices in the setting of cardiogenic shock. The team has also done a really great job looking at the trajectory of worsening renal function over time. Again, for the left, with no worsening renal function, you can see pretty stable and improving eGFRs. But on the right, with worsening renal function, there's a vulnerable period in that first 48 to 72 hours. If you can't stabilize them, it becomes very difficult to actually optimize their care. And this is what Rachna and the team are showing, that essentially there's worse outcomes with worsening renal function. So again, another multifactorial target that we have to really focus on best practices and optimizing drug as well as device utilization. Now, I'm going to end with acute limb ischemia. I think this is a really important one. It's a dark horse, in my opinion, that's driving poor outcomes in shock. These are the rates from balloon pump, danger, as well as ECLS shock, showing, again, a range of 4.3 up to 11% of limb ischemia with the various technologies, again, increasing with French size as you go from smaller to larger devices. These are our shock data that were led by an analysis from Ajar Kochar, and essentially showing a stepwise increase in the prevalence of acute limb ischemia using different technologies across the spectrum of cardiogenic shock, getting all the way up to 16.6 to 18.8% when you combine the therapies. Now, in-hospital mortality when you have the presence of acute limb ischemia doubles, and this is why acute limb ischemia is important. So when we look at the predictors of acute limb ischemia on the right side, female sex, peripheral vascular disease, MI, cardiogenic shock, and greater than one MCS device, these are the things that we can try to modify to optimize, and it's where we absolutely need to have more innovation. Now, limb ischemia is important because it impacts length of stay, it impacts other complication rates, and it impacts hospital cost. So this slide summarizes that, and of course is there for your review. Now, right now, our approaches to manage acute limb ischemia, I think, are an example of where we don't have best practices. We don't have innovation yet. We have challenges detecting limb ischemia early enough. And when we do, right now, if you're not using VA ECMO, we're stuck with techniques like this, where we do passive bypass, which is dependent on native blood pressure. Or we do active bypass, where we use an external ECMO circuit. And the problem there is now your limb perfusion is dependent on your ECMO pump. So if you're weaning, you may start to get limb ischemia during the weaning phase. And none of these protocols have been optimized. The technologies are not optimized. We are essentially MacGyvering our way through these cases because we don't have uniform best practices. And that's where the registries like Shock Working Group and AHA and all the data that's coming out will become so important. So I'm going to end with the messages to take home. The danger shock illustrates the importance of patient selection in RCTs to demonstrate reduced mortality with transvalvular unloading. And I think they really threaded the needle by optimizing their thought process, as you saw from that inversion thinking exercise. Cardiogenic shock complications occur with drugs and or devices. Clearly, with the presence of devices, there's an increased risk, and the combination of devices makes it worse, and we have to figure out how to optimize care. But bleeding, limb ischemia, stroke, worsening renal function, and hemolysis, they're all multifactorial conditions, and what they demand are improved definitions, improved clinical application of best practices, which we need consensus on, improved device innovation that year over year reduces risk, as we learn with all of these technologies coming out. And then this integration of critical care and cardiology, is an absolutely important step to optimize outcomes for our patients with cardiogenic shock. So thanks very much for your attention.
Thank you, Navin. And so as we shift over to Mauro and ask him to go ahead and pull up his screen, I will, as always, Navin, so many clearly stated but provocative and interrelated ideas. I hope folks will take Shana's advice and start putting questions into the chat. but I think we're also going to complement with Mauro Moscucci from the FDA. And more if you, there you go. From the regulatory perspective, very safety oriented. And it's my privilege to introduce Dr. Mauro Moscucci, from the Division of Circulatory, Vascular, and Structural Heart Devices at FDA. Mauro? Mauro, you might be on mute. There you go. Now we hear you. And we see your slide. Thanks.
Thank you for the introduction. It is a pleasure to provide this commentary. I have nothing to disclose. I would like to start by saying that Dr. Kapur has provided an outstanding state-of-the-art review of where we are in the field of cardiogenic shock, current and future challenges, and he has set the stage for future efforts. The DanGer trial can be considered a landmark clinical trial, as it is the first randomized clinical trial showing a survival benefit of mechanical circulatory support in a selected patient population with cardiogenic shock. As highlighted by Dr. Kapur in his presentation, lessons learned from the DanGer trial include the value of selective exclusion criteria and of a randomized clinical trial study design. It also sets a new equipoise that will need to be considered in future clinical trials design. In addition, the trial results highlight the delicate balance of the benefit-risk profile of mechanical circulatory support devices, where a survival benefit may be counterbalanced by a high incidence of adverse events. From a public health perspective, the role of FDA in the evaluation of mechanical circulatory support devices is to obtain reasonable assurance of their safety and effectiveness, and to ensure that patients and providers have timely and continued access to effective and high-quality devices. These goals introduce the concept of clinical benefit. As you know, clinical benefit can be defined as a clinically meaningful effect of an intervention, meaning a favorable effect on how an individual feels, functions, or survives. It can be demonstrated as either a comparative advantage in treatment of a disease or condition, or a comparative reduction in treatment-related adverse effects. When evaluating and comparing clinical benefit and the benefit-risk profile of cardiovascular devices, a device can be more effective and safer, which would be the ideal situation, whereas effective and safer, which is still a very desirable outcome. It can also be as effective and unsafe, less effective but still safer, or less effective and less safe, which would obviously be the least desirable outcome. There is no question that based on the progress made with the DanGer trial and the additional information provided by Dr. Kapur in his presentation, there are new opportunities for strategy trials in cardiogenic shock focused on safety, including limb ischemia, bleeding complication, understanding acute kidney injury and how to prevent it, and better understanding of cardiopulmonary injury. I would like to say just a few words on when an investigational device exemption, or IDE, may be required. In general, the requirement for an IDE applies to all significant risk clinical investigations of devices aimed to determine safety and effectiveness. When it is determined that there is non-significant risk, there are situations where an IDE may not be required. The FDA website has many resources available regarding when an investigational device exemption might or might not be required. We strongly encourage sponsors and investigators to talk to us early in the process. The FDA Q submission program provides a mechanism to interact early with the FDA through informational meetings, pre-submission meetings, and pre-submission written feedback. I can add that the FDA has been working in close collaboration with the MD EpiNet Shock Group, the Shock Academic Research Consortium, and the HA Registry to develop least burdensome and efficient clinical trials and hypotheses that maintain scientific validity. I would say that multiple stakeholders need to be involved to get this right. I would like to conclude by saying that the evaluation of devices for cardiogenic shock presents many challenges from a study design and clinical perspective. There has been significant progress in the development of clinical trials, standardization of definition, the development of collaborative groups and registries, and more recently, a tremendous progress with the conclusion of the DanGer trial. FDA support the development of creative study designs aimed at obtaining scientific data demonstrating a reasonable assurance of safety and effectiveness, and in identifying strategies aimed at further increasing the safety of mechanical circulatory support devices. Thank you for your attention.
Okay, David, I think Mauro set the stage. While people are thinking about, we have one question in the queue already. Let me just ask both Navin and Mauro briefly to help us understand how to even begin to tackle the complex sequence you've described for complications if a patient has multiple or serial MCS devices put in. Since if an event happens after a device is newly placed, your mind may go to the new one as the problem or the new procedure as the problem, but actually the indwelling device that the new one was added to has been in the circulation for a longer period of time and may have its own issues. Or as Navin, you showed with the shift of the cloud, so to speak, in mixing, is it the interaction between the two? How do you systematically go about gathering data to create evidence on where the problem is in the first place? Navin, you want to start?
Yeah, well, thanks, Mitch. I mean, I think that's the real exercise here. You know, you sort of answer the question at the end there. I've been saying for the last 17 years that, you know, we need lots more data in cardiogenic shock. We're in a data-free zone for a long time. We're now finally beginning to accumulate data. You can see the real world data and how it differs from the RCT data. You know, the real world data actually, you know, shows in some cases, you know, better results, but in other cases shows worse results. So we've got to get a better handle on what's being done in clinical practice today. And that requires immense amounts of data. Number two, I think that, you know, there's immense expertise that's developing in the field, and we need to get to consensus on what are considered best practices. Now, with danger, for example, we finally have some data from RCTs to actually guide some of those consensus and some of the guidelines. But I think there's a lot more work to do. And the complexity of these patients, even from a drug perspective, and I really want to emphasize that because we're quite focused on MCS, but I think even with drug escalation, we know that once you get to 2 to 3 vasopressors, in the vast majority of community hospitals or centers that are not at tertiary quaternary care centers, that's the hemodynamic support strategy. And we've got to figure out how to understand that better and really figure out what are the trigger points that, you know, allow us to escalate and do it safely. So I guess to answer your question, it's going to be a lot of data, and it's going to be a lot of experts looking together to build and develop guidelines and recommendations for consensus. And I think we're starting to see that. I would use the ECPR guideline from AHA in December of 2023 as a really nice example of taking early data, RCTs, making recommendations, and then following it and pairing it with a expert consensus driven algorithm.
So Mauro, again, you're obviously working from the Center for Devices, but as Dr. Kapur has brought up, and we all know, how these devices behave frequently do interact or depend on adjunctive drug therapies. And not to mention the fact that as shock becomes a systemic state, how drugs behave also can be very complex. So from the FDA's perspective, how do you guys go about considering not just how much data, but what data or what kind of data would actually be informative to understanding the root cause of these kinds of safety events?
Well, you know, Navin has provided a very nice overview of differences between different devices. and of the complexity in adjudicating an adverse event, particularly when you have this device escalation. Within cardiogenic shock, different devices have different adverse event profile. In addition to that, there are procedures that are done to address some of the device adverse event that can have their own complication, which lead to the huge complexity in a sort of appropriate adjudicating this type of events. From our perspective, it's critical to have a good overview of the totality of data that allows to have an appropriate assessment of the temporal relationship between different device escalation adverse event and additional relationship between adverse event that may be related to pharmacological intervention versus the device itself.
Navin, I'd love to take things, that was a spectacular talk again, and I'd love to take things in a practical direction for the incredibly large audience that's listening today. And just if you were to articulate maybe the top 3 things that people can focus on in their clinical practice around the bleeding and access injury, perhaps as a focus, what would you give to all the practitioners on the line as advice?
Yeah, it's a great question. So I couldn't put that into a slide, so I'm going to try to I'm going to try to put that into words here. But I would say a couple of things. Number one is the vascular access itself, in terms of device implantation, has a series of best practices that have to become mandatory. They have to basically become required using micropuncture ultrasound. There has to be a lot of training. We're seeing a lot of interventionalists who are very good at radial and are no longer comfortable with femoral. And there is, of course, the TAVR experience, but there's a lot of things we have to learn in a multidisciplinary way just for getting access and deployment. And under that, I would bundle, VA ECMO. VA ECMO is still very much a surgical principle, yet it's being now more directly applied by non-surgical personnel. And so as a result, the technologies and the techniques have to modify and be updated to optimize for that group of operators. The second thing I would say is that during when you're on support, whether it's ECMO or whatever platform, this meticulous management of anticoagulation is critical. Use of bicarb in the purge because of the anionic substrate for Impella, I think, is a great step forward to get away from having super therapeutic anticoagulation. But close monitoring of ACTs, 10As, and PTTs, as was brought up in the chat, I think is something that has to be protocolized. We don't have protocols around that. We have recommendations, but that's quite varied. And then the third is, the most important thing, Jamie McCabe, an operator at University of Washington, always likes to say that, when doing gymnastics, it's all about the dismount. And at the end of the day, the bottom line is, how do you take these devices out safely? And, we don't have uniform techniques. We have different operators doing different things. We're learning that also in the RCTs. And there are different closure devices, as Mauro mentioned, and those have their own complications. So I think that dismount aspect, there are some fundamental things that can be done. One is to get your institutional best practices lined up. The second is to make sure that you're not super therapeutic. We're still seeing devices removed with super therapeutic anticoagulation, and that can also increase complication rates. But so many little steps, and I think a lot of this actually comes down to nursing principles that a lot of doctors tend to gloss over. So I would encourage our nursing colleagues to put together their expert consensus statement. I certainly have been slapped around by many nurses for decades now, and I've learned so much from them that I think this is a great opportunity for our nurses to take the lead and help us understand what it's like at the bedside and how to optimize care.
Yeah, no, I think that each of those points is spot on, and it brings to light the point you made earlier, which is that care of these patients is really a team-based sport that spans the beginning in the cath lab through their meticulous care in the cardiac ICU, and as you point out, how they land as well, and it's collaborative among disciplines and different providers who are all involved in taking care of these patients. I think we do need to go ahead and turn to our case. There'll be a little bit more time at the end as well for an open Q&A, but I think this case will nicely tie together some of the principles that Dr. Kapur has already introduced and then give us an opportunity for some more discussion at the end. So it's my great pleasure to introduce Balim Senman, who's a fellow in critical care medicine at Duke after having completed her cardiology fellowship as well, and is a leading voice in the field among trainees in critical care cardiology. So the floor is yours.
Thank you, Dr. Mauro, for that introduction and including me in this wonderful discussion. These are my disclosures. All right, so just a couple of objectives to assess the adequacy of temporary MCS and indications for escalation, as well as to describe common complications of temporary MCS and management priorities. So we have a 56-year-old male who has a past medical history of type 2 diabetes, hypertension, hyperlipidemia, as well as obesity, who's coming in with 1 month of worsening shortness of breath, inability to lie flat, and just generally feeling bloated. He's brought in by his wife, who's very worried about him. About 6 weeks ago, he had a bad bout of the flu, and he figured he caught something from his granddaughter. In terms of his social history, he works in construction, he's married, he has 3 adult kids, he denies any alcohol use, he quit smoking over 20 years ago, and he has no history of e-cigarette or illicit drug use. He himself is adopted, he doesn't know the history of his biological parents, and all 3 of his kids are alive, well, and healthy. So on presentation, his vitals are pretty concerning. He's tachycardic to the 110s, he's hypotensive, and he's satting about 90% on room air. He's unable to really form long sentences, and on exam has diffuse crackles in his lung fields and 2+ bilateral edema. In terms of his labs, they're largely indicative of a congestive picture. He's hyponatremic. He has a new AKI from a baseline of 1.3 to 3.1. His CBC is largely unremarkable. He does have a new transaminitis with his AST/ALT in the 400s band. His NT-proBNP is remarkably elevated at 25,000 with as well as a high sensitivity trope of 180, and he has a lactic acidosis of 7. His EKG is largely notable for sinus tachycardia. He doesn't have any overt ischemic changes. His chest X-ray is notable for diffuse patchy findings consistent with bilateral pulmonary edema. And then a quick echo is done at bedside that shows a reduced EF of about 20%. There's no regional wall motion abnormality. He has mild MR, moderate TR, and a mildly reduced RV function. So he's quickly noted to be in SCI stage 3 shock, and he started on norepinephrine for pharmacological support of his shock and taken to the cath lab for a coronary angiography as well as a right heart cath. His coronary angiography just shows diffuse mild CAD. There's no culprit lesion or concern that an acute ischemic event is driving his presentation with cardiogenic shock. His right heart cath is consistent with cardiogenic shock and congestion. He has an RA of 17, a wedge of 30 with an index of about 1.6. And so the decision is made to place a femoral balloon pump to further support him through his shock. He's then brought to the CICU. Next day, unfortunately, his clinical picture is not improving. He's now in AFib with RVR in the 150s, rendering his balloon pump not the most efficacious. He's still hypotensive. He's satting still marginally at 93% with 5 liters of nasal cannula. He's becoming oliguric to anuric and appears just more somnolent. His labs are also indicative of a worsening clinical picture. His AKI is worsening now at a creatinine of 4.5. His transaminitis is continuing to evolve. And his lactic acidosis, concerningly, is not clearing and, if anything, worsening. His leave and right heart cath continues to show a very congested picture. So in the setting of this, he has additional vasoactive medications added to his care, but unfortunately, this is without benefit. He continues to be in profound cardiogenic shock. He's intubated given his poor oxygenation status and started on renal replacement therapy given his anuric state. And given his worsening clinical picture, a shock team is activated. And with the components of the shock team being CT surgery, interventional cardiology, critical care cardiology, advanced heart failure, as well as social work, the decision is made that he's actually of suitable age for advanced therapies. He has no prohibitive comorbidities. He has a great support system, always at bedside. He's a good advanced therapies candidate as things stand. And in the setting of the evolution of his cardiogenic shock and currently for mechanical support, the decision is made to put him on ECMO as a bridge to transplant. The following day on exam, he's noted to have a leg that's noted to be cold and mottled on the side where his ECMO catheter was placed. And the vascular site is without any evidence of hematoma or bleeding. So this is concerning for vascular access site complication, as Dr. Kapur had noted too. This is as the degree of support increases in terms of what we use to help our patients. Unfortunately, the access site complication increases as well. And this is largely governed by the fact that higher levels of support are needing larger French sizes in order to be able to deliver the needed flow to the patients. And the access site complications are many, ranging from dissection, pseudoaneurysm formation, retroperitoneal bleeds, as well as infection, bleeding, and ischemia. So in this patient, he's noted to have an ischemic leg, and he's emergently taken back to the cath lab for a DPC placement. Thankfully, following DPC placement, his leg is salvageable. It regains color and warmth. The following 4 days, initially the patient is actually showing some clinical stability. He's improving in his hemodynamics and some of his perfusion markers. His urine output is starting to improve, and he's trialed off of renal replacement therapy, but he's still intubated with very high ventilatory settings. You note that, or he's noted that on his pulse ox on his right limb, he's satting about 83%, but when an ABG is obtained, he actually is satting well with an oxygenation of 300 on his ABG. So, and then on exam, and this is an exaggerated kind of depiction of his exam, he's noted to be more hypoxic in his upper extremities and well perfused in his lower body. And as Dr. Kapur had alluded to, this is noted to be pretty quickly north-south or Harlequin syndrome. This happens when there is a good cardiac recovery in a patient, but unfortunately the recovery of the pulmonary system is lagging. And what turns out to be is that the poorly functioning pulmonary system sends poorly oxygenated blood to the heart. And because the heart has had good recovery, it is able to pump this to the upper part of the body. The lower part, however, is still supplied by the retrograde perfusion of the ECMO catheter. And depending on how much support the patient is receiving from the ECMO catheter, there's now a creation of a mixing cloud in the patient where the upper limbs are supplied with deoxygenated blood, and the lower limbs or the lower part of the body is supplied with oxygenated blood from the device. And so there are essentially 3 ways to target this, and it really depends on how well each system is is recovering. If there's good cardiac recovery and a reasonably well, and the patient is reasonably well supported by the vent for their pulmonary status, then an attempt to wean the VA ECMO to decannulation can be trialed. If there is good cardiac recovery, but the patient is not reasonably well supported on the vent, still requiring very high vent settings, then the patient can be transitioned from VA ECMO support to VV ECMO support as they've had good cardiac recovery. Or if there's need still for cardiac and pulmonary support, then the patient can be transitioned from VA ECMO to VAV ECMO. And so in our patient, as he was having good recovery for his cardiac function, he was transitioned from VA ECMO to VV ECMO to really support his lung recovery. Unfortunately, 3 days later, the bedside nurse reports that the patient had a change in their exam. They're unable to elicit cough, gag, or pupils. This is immediately concerning, and he's sent for a stat imaging that shows that he had a hemorrhagic bleed, unfortunately, with midline shift in his cranium. And so, again, as it has been alluded prior during this talk, whenever a temporary MCS device is deployed, there's always a risk versus benefit in terms of ischemic complications versus hemorrhagic complications, need for anticoagulation, and changes in the patient's perfusing parameters. For this patient, upon hearing this devastating news, the family expresses that they wouldn't want further interventions in this patient, as this would not be aligned with his goals. And he's transitioned to comfort care and passes comfortably surrounded by his family. Thank you.
Yeah, no, so thank you very much for presenting the case. I think it's definitely a sad case for all of us to see. I think it speaks to the fact that we are constantly balancing the complications of the care that we provide, and in particular in this case where there was myocardial recovery, but ultimately it was the complications of the supportive care that contributed to his lack of survival is exactly why we want to think about this issue. There's a lot to talk about it in this case. Certainly want us to spend a little bit of time on the complications, and we welcome anyone to put their questions in the chat and we'll get to them. Maybe I'll ask you to open up, Navin, on just what your approach is in terms of utilization of a shock team and the timing of escalation. This is a little bit off the complications, but just in the initial management of this type of patient, and when and how you decide and who's involved in early escalation before there's more end organ injury like there was in this case.
Yeah, thanks, Dave. And, congrats, Balim. That was a really terrific presentation. You hit on, I didn't talk to you before the session, so you really hit on all the topics. So I would just say that, in our center, there was a change about 7 or 8 years ago where the point guard for MCS, acute MCS, transitioned from basically being in the cath lab to basically being in the critical care CCU. So our critical care intensivists are really the ones who are looking very carefully when a patient comes out of the cath lab in the first 3 to 6 hours, and then the first 24 hours. They're meticulous monitoring of lactates, all the metabolic parameters, lung function, mitigating complication risk. It's way too much for an interventional cardiologist or an advanced heart failure transplant person to take care of by themselves, because they have a very busy practice that they're already managing. So I think actually the future really relies on cardiac critical care intensivists to receive that patient from the operating room or the cath lab or the ER, and then to really call the shots. The heart team approach, I think, is critically important for specific decisions, but our personal bias is that the way to efficiently expedite care is to have a predetermined algorithm that has consensus within the institution, so that you don't require a long conversation and chasing down people to make the next step decision. That can be an algorithm that's implemented by the intensivist.
Yeah, and I think setting those benchmarks for evidence of ongoing malperfusion and worsening malperfusion is incredibly important for triggering escalation for more support when it's clear that you need it before there's substantial end organ injury. Mitch, you had a question.
Yeah, Balim, that was awesome. And really, it really hit so many of the key items, as the others have said. What it triggered in my mind as well is because, as Navin pointed out, the danger shock data are essentially STEMI shock. And what you've described to us is another universe that I think we really have to contemplate, which is that if you don't have a sudden crushing chest pain moment that brings you to the hospital, how long was this gentleman actually wrestling with this at home? His first numbers while he was walking around, God knows if he was even going to work, were pretty scary. And yet, how many weeks? So it's not just could you get the shock team in a couple hours faster, which is still a key question, but how much more of the universe as we get out of the STEMI universe and into the real world of cardiogenic shock is going to involve a whole other level of pre-hospital awareness, pre-hospital detection, et cetera. And ultimately, in that spectrum of time, how much of what we're dealing with in the downstream need for escalation of devices and the later stages of trying to reverse physiologic catastrophe, how much of that could we, by doing a better job at time to detection, but how much of a challenge is it when a patient lives in shock at home? I just think is another universe that this case really points towards.
Yeah, couldn't agree with that more. I know that's an area that Navin's been working on for a while as well, and early detection. And so we all try and sort out what pre-shock means and how we might discover it even earlier. I guess there are one quick question, and then maybe Navin, you can expand on your response to Aniket Raleigh in the chat, because I think it is an important one to think about the inflammatory milieu. But first, what is your approach with distal perfusion catheters? Do you usually put them in presumptively when you cannulate for ECMO, or do you take a watch and wait and see and evaluate the limb closely and then make a decision as the case unfolds?
Yeah, our approach is 80% of VA ECMO peripheral cannulation gets a DPC empirically. I would say there are 20% of cases where we clearly know that the artery is, of sufficient size to accommodate a cannula. Two additional points. One is we are trying to now reduce the cannula size that we cannulate with on the arterial side, especially if we're doing ECPella, to try to optimize what we call low flow ECMO and high flow Impella as we transition patients. And the second point is that the real challenge for limb ischemia is when we don't have ECMO. So when you're forced to do things like passive bypass in the setting of balloon pump ischemia or Impella limb ischemia, for that category of patients, we don't have a solution.
And then with some eye on the time, we have about 2 minutes left. It is a very interesting question from Aniket Raleigh about the role of inflammation and that inflammatory milieu and some of the complications we have in these patients.
Yeah, just briefly, I responded to Aniket online and said that he asked about inflammation and whether that should be a target of therapy. And I just said it's essentially a double-edged sword, right? It's necessary for the response to injury and healing, like you get with an acute MI, but it has significant off-target effects. The other point that I didn't put in the chat is that, the effect of these technologies on inflammation is still wide open. We're studying intensively VA ECMO, the inflammasome, and how things are mitigated at the renal level, the aortic level, the brain level, and at the heart level. And they're not load dependent. So that's an important difference there, is it's not just about hemodynamic load. So when we say loading devices, that's really only an aspect of the ECMO. The oxygenation is another big piece of it.
Yeah, and I think Anikit's question also gets at the experience that we all have, which is that often these patients who have substantial initial afterload that they have developed compensatorily, then once we support them with mechanical support, they end up with a release of cytokines and get quite vasoplegic. And that course of their therapy can be in their clinical course can be quite difficult to manage, and is often the point where it's very difficult to rescue them, no matter what we might use to help them. All right, well, I want to thank all of our speakers and all of our attendees for joining us and your questions. It really is an absolute pleasure to have heard from this fantastic lineup today. Really a terrific conversation, and I think such an important one as we set the stage for more data to, as Dr. Kapur called for, to really drive the best practices that we try and develop that should be evidence-based. And there's such a prevailing unmet need still in this field for us to develop approaches to safely care for these patients. So thank you all. This
Also, David, want to call out our
Go
FDA
ahead.
colleagues for being willing to pitch in and comment in, and we work, I think, on public health as an ecosystem, and they are obviously a critical part of that ecosystem.
I can add that it has been a pleasure to be part of this effort.
And I think on that note, we'll go ahead and close today's session. Thank you all for joining.
Thanks, everybody.
Thank you.
Take care.
Bye.